Okay, the second one. So, so this is how the lung cancer therapy has evolved over the last 3 decades, I think. So it used to be one entity, but then it became two, and non-small cell, small cell, and then NSCLC was broken down into squamous, non-squamous, large cell, adeno. And now we are into the molecular era where we are looking at EGFR, ALK, ROS1, and even more, which I'll just show you. And of course, currently we are into the PDL1 and TMB era. So this is how the whole thing has evolved. So today we're going to be talking on the next slide on the EGFR. So as I said, so it is not only EGFR. So I think we're moving on to ALK, MET, ROS, BRAF, RET, the drugs are available, NTARK, MEC1. So, various phases, and these are the various percentages. So I think it's really becoming very, very personalized when it comes to a lot of malignancies, and lung cancer is actually taking the lead there. Next, please. So this is the timeline for development of EGFR targeted drugs. So in 1997, it entered into clinical development. So it was only in 2009 and 10 when we had the data which supported the use of gefitinib versus chemotherapy and erlotinib in the optimal study, better than chemotherapy. So these were the two drugs which really, ruled for a few years. And then, of course, the Lung 3 and 6 demonstrated the efficacy of afatinib, which is a second generation TKI. And then, of course, we have the osimertinib in second line for patients who are T790M positive, where you can detect T790M either by plasma, ctDNA, or if not, then you have to do a biopsy. So the AURA studies demonstrated the efficacy in second line. And more recently, we have the data with decometinib versus gefitinib in the first line, the Archer 1050 study, which I'll show you. And so, in 2018, we have the FLAURA study, which demonstrated superiority of osimertinib over the first generation TKI. So, this is what we all know. So I'll take you through some new stuff which is appearing in the EGFR targeted drugs. Next, please. So I think this is an important slide which shows you the various mutations or deletions. So deletion 19 in the exon 19 in EGFR constitutes 46%, and EGFR L858 are 38%. So, most of these are here, which are sensitizing mutations most of the times. But then I think there is understanding of the other mutations, for example, in exon 18, and the other mutations, then these 19 and 21. And then, of course, 9% of the mutations in the exon 20 are insertions, in the exon 20 insertions. So this is an important chunk of which the development is taking place. Next, please. So I think we all know about gefitinib, erlotinib, and afatinib. So this is the new study, which is the FLAURA study, where gefitinib or erlotinib was compared to osimertinib 80 milligram once a day in the first line setting with patients having exon 19 deletion or L858R. And the crossover was allowed for patients in the standard of care arm who would receive open label osimertinib upon central confirmation of progression and T790M positivity. So PFS was the primary endpoint. The objective response rates, duration of response, overall survival was the secondary endpoint. Next, please. So this was the NEGM study, and this has shown clear benefit in terms of PFS, 19 months versus 10 months in favor of osimertinib. And the hazard ratio for overall survival is 0.63, and the p-value is significant. So the osimertinib has really come up as a standard of care in the first line as compared to the first generation TKIs. Next, please. So this is the other significance of osimertinib. As you can see, the drug crosses the blood-brain barrier. which gefitinib and erlotinib don't do that well, and therefore there is data to support the efficacy of osimertinib in patients with CNS metastasis. Next, please. So this is the 2019, there's I think a latest upgrade on the first line treatment for EGFR mutated non-small cell lung cancer, but osimertinib is preferred category 1. However, erlotinib, afatinib, gefitinib, and decomatinib are also category 1, which could be used in all patients who have EGFR mutation. Next, please. So coming to the newer data, which is the decomatinib versus gefitinib. So as you can see, the progression-free survival with decomatinib is significant, is better, 14.7 versus 9.2, and the hazard ratio is 0.59. P-values are highly significant. So the issue with decomatinib, the next slide shows the next slide. It shows you the overall survival, which is the hazard ratio, as you can see, and the curves are sort of little better than the gefitinib, and hazard ratio and the p-value is just crossing the significant mark, and the decomatinib is supposedly you see the median overall survival of 34 versus 26.8 months in favor of decomatinib. So this is another drug which has now become available. However, the problem with the drug is, next please. So it is here that you see the side effects, and nearly 66.5% patients require dose reduction. And these are basically class effects like dermatitis, diarrhea, paronychia, and stomatitis. So this is a drug to be kept in mind. Next, please. So now coming to the newer aspects which are emerging, which are the combination of EGFR drugs with other combinations such as VEGF inhibition. So there are a few trials. Erlotinib with bevacizumab versus erlotinib alone has shown 16 months versus 9.7 months, and which is hazard ratio is 0.54. So again, talking about superiority of this combination over erlotinib alone. Next, please. So this is the other relay study where ramucirumab or Cyramza was combined with erlotinib in again first line setting with patients who have these common EGFR mutations, and T790M was excluded from this. Next, please. And again, like the bevacizumab data, you see 19.4 months versus 12.4 months. So if you remember the osimertinib PFS, which was again in the line of 19 months. So ramucirumab in this along with erlotinib gives you a significant PFS advantage, and you can see the p-values and the hazard ratio. Next, please. And this is the overall, this is the progression-free survival and interim overall survival. Again, the hazard ratio for interim OS is 0.832 and for PFS2 is 0.690. So again, you are getting towards that 19-month mark with either osimertinib or combinations of different drugs combining with EGFR inhibitor. Next, please. So this is a summary to show that erlotinib plus bev versus erlotinib, 16 versus 9.7. Again, in non-squamous, in another trial, 17.9 versus 13.5 months, erlotinib versus bev. And here you see erlotinib plus ramucirumab, again the p-values are significant. So I think the combination is with either ramucirumab or bevacizumab gives you a superior sort of outcome than as compared to the first or a second generation TKI. Next, please. So on these very lines, so osimertinib is now being combined with bevacizumab on a 3-weekly basis to see whether you can cross that 19-month mark on the progression-free survival. And of course, as we know, we have the advantage of osimertinib crossing the blood-brain barrier. So I think 150 patients in each arm are being recruited, so the data is yet to come. Next. So this is the other thing which has come from Tata Memorial, that is combining gefitinib with chemotherapy. Next, please. And so which is a much cheaper study. For example, chemo, as we all use with gefitinib, was compared with gefitinib, 175 approximately patients in each arm. And we know the results. Next, please. I mean, they clearly show that the progression-free survival, you can see here 16 months versus 18. Again, that 16 to 19 month mark as compared to gefitinib alone. And the overall survival, again, you can see is superior here, which is not reached in the combination arm than as compared to gefitinib alone. So the p-value is highly significant. So this is again a landmark study from Tata Memorial, where the combination of chemo with gefitinib is better than Gef alone. Next, please. So these are the side effects. I think I think we can notice there. Chemotherapy does add on to toxicity, but I think the drug delivery was fair, and the response rates were like as expected. Next, please. So these are the two studies, one from Tata Memorial and the other is from Japan. Again, gefitinib plus carbo-pem. You can see the overall survival touching 50 months versus 38 months, and hazard ratio is 0.72, and the p-value is significant. So these are promising data for combining chemo with carbo-pem from at least centers. I think needs to be taken forward. Next, please. So this was the summary for various TKIs and TKI combinations. And so this is what we understand, that not only do we have deletion 19 and mutations in exon 21, but there are issues in exon 18 and in exon 20. So which is what I will address in the next part of my talk. Next, please. So now this is an important slide from Ledek et al. In 2017. So as you can see here, the exon 19 does the best, and the green is L858R. So they come number 2, but the other, for example, the exon 18 mutations or exon 20, so the curves are much lower. So the standard first generation TKIs are perhaps not good enough for these exon 18 and for exon 20 insertions, in the exon 20. So, this is a study where they had 1,837 cases. And it's an important study to see here that the survivals are much lower for patients who have exon 18 and exon 20 insertions. Next, please. So this is again from the same Ledek et al. Study, which shows you the survival in exon 19 and 21 is pretty good when you give chemotherapy, as you can see here. This is the PFS 10 months, 10 months. But when you come down to 18, the PFS with chemotherapy and PFS is 6.4 months, and with exon 20 is hardly 3.9 months. So these are important, issues for exon 18 and 20, which we need to address. Next, please. So there are basically afatinib is the drug which has data for exon 18 mutations, as you can see, 66% OR, and the duration of response is 52% at 12 months. And similar data is also reported for osimertinib with a median PFS of 9.5 months. So for patients with these uncommon mutations, one should consider afatinib, osimertinib, and not use the other drugs. Next, please. Again, to show you the same thing, that exon 19 and L858R do the best, but the exon 18 and the exon 20 insertions, they don't do well. Next, please. So what about exon 20 insertion? So I think, as you can see here, in the exon 20, there are several insertions which are actually thought not to be equal in terms of drug sensitivity, and the data is emerging in that direction. Next, please. So I think this is the same. This is a sort of a little complex slide. I will just not go into the detail of this. Time doesn't permit. Next, please. So this is the data for exon 20 deletion or insertions. This is the first generation TKI like gefitinib or erlotinib, and you can see the red curve here, or the this curve is the EGFR TKI. So actually they don't do well when you treat them with gefitinib or erlotinib. However, next slide. There is data for patients treated with afatinib or with osimertinib. There is some data to support their activity in exon 20 insertion or their deletion, duplication. So next, please. But I think the new drug which is emerging now is poziotinib, which you can see poziotinib here. So it gives you the maximum reduction in the tumor when you treat these patients with exon 20. And these slides, they show you a pretty good effect on the CT scans where the tumor seems to have shrunk quite a bit before and after poziotinib. So this is a promising molecule for exon 20 insertion and duplication. Next, please. So this led them to do a study for patients with the exon 20 insertion. And this is cohort 1 who was previously treated. And just go to the next slide. And you can see in cohort 1, almost tumor shrinkage is reported in 65%. So fairly promising outcome. And similar study from MDACC shows 43% response rate. So if somebody is diagnosed with exon 20, insertion, so we should think of a molecule like poziotinib. Next, please. And the issues of tolerance are there, so we'll not go into the details of that. Next, please. 88% had drug interruptions. So this is the other molecule, TAC788, and again you see a response rate of 43%, and the duration of response is also fair. Next, please. So this was about all the mutations which I could cover from the EGFR, the latest information. So what about treatment of patients who fail the TKI in the EGFR mutation? Next, please. So I think this is after, say, first generation or second generation TKI, where T790M constitutes about 60%, HER2 mutations 8%, and MET and these also constitute about 6 to 7%. Small cell transformation and HER2 also constitutes. So you need to target the T790M by doing the plasma testing. If it is negative, then you must do a tissue biopsy to look for T790M if you have exposed the patient to first or second generation TKI. Next. And that is because the AURA3 has clearly shown the efficacy as compared to chemotherapy in the favor of osimertinib. Next, please. And similarly, the CNS overall response rates are tremendous. So it's a fantastic drug for patients with CNS metastasis because you get responses there as well. So osimertinib, after the failure of first or second generation TKI with T790M, is a wonderful drug. Next, please. And you show the efficacy in the Bloom study where there was meningeal metastasis, and you see the responses to the tune of 43% in T790M patients. Next. So this is another mutation which happens in patients who are exposed to, the TKIs, and patients who have a trans mutation that is on a different, the mutation of T790 C7S is on a different strand of the DNA as compared to the T790M. They tend to respond to the gefitinib along with osimertinib. So this needs to be also kept in mind. Next, please. So this is the other important area which we also need to understand, that patients who have EGFR mutation and who fail on first, second, or even third generation TKI, and they don't have a targetable mutation. So those are patients whom we should try a 4-drug combination, which is atezolizumab, Bev, and CP. So immunotherapy has a role along with chemotherapy and bevacizumab. You can see the hazard ratio in favor of immunotherapy arm versus the non-immunotherapy. Hazard ratio is 0.54. And I have a few patients who are doing very well for more than 6 to 9 months on this particular combination after failure of first or second generation TKI if they don't have any targetable mutation subsequently. Next. So finally, the resistance mechanisms to either first or second line osimertinib would be different. Obviously, T790M is not going to be there, but you can see C797S and the HER2 amplification or MET amplification are the common targetable mutations once you have exposed these patients to osimertinib. And as I told, that the gefitinib is the one which works in C797S, but then for MET and HER2, you need to have different drugs which are perhaps becoming available. But this is an evolving line of management at this point in time after the patients fail osimertinib. Next. So this is my last slide to show that when you treat patients in a sequential fashion with erlotinib or gefitinib, you will get about 10-11 months, and then you can put patients on osimertinib after chemo with immunotherapy. But osimertinib, you can see here, gives you the maximum progression-free survival, which can be followed by chemo plus immuno. But I think the data for VEGF plus EGFR TKI is emerging very rapidly, and I've shown you data on chemo plus EGFR TKI, which is approaching osimertinib. So which can be here, you can follow it up with osimertinib if the T790M is there. So these are important two areas, and as I showed you, they're combining or trying to combine osimertinib with a VEGF inhibitor, which could surpass, who knows, 20 months of PFS. So the data is pending at this point in time. So I think we've come a long way in the understanding of particularly adenocarcinoma non-smokers with EGFR mutation. So we need to do relevant tests to identify appropriate, a target or appropriate mutation or insertion, and then give a suitable treatment so as to get the best out of personalized medication. So I think with this, I stop here, and thank you very much to the organizers, especially Dr. Sachin, for inviting. Thank you.